A racing car driver often has to meet life and death situations in the course of a thrilling drive and still goes scot-free. Sometimes in the life of an ophthalmic surgeon, a decision has to be taken on the OT table, which, however daring, bold, and somewhat rash, can be the best one considering the circumstances. A 74-year-old practicing dental surgeon presented with a dense, early brunescent cataract with a vision of 6/60 in the left eye. The biometry results made him a suitable candidate for a T5 Acrisof toric lens with a power of 25 diopters to be placed at an axis of 96 degrees for a correction of a pre-op cylinder of 4.25 diopter at 95 degrees. Incision location was 90 degrees, clear corneal with an intended placement of a T5 Acrisof toric lens at 96 degrees and hence the markings as seen. Under peribulbar anesthesia, a regular 5 mm capsular rhexis was performed, followed by hydro procedures. Using viscoat in a soft shell technique, phaco was started in a stop-chop method, needing considerable maneuvering. Irrigation aspiration was completed, and at the end of IA, I realized that the anterior capsular rhexis had extended peripherally at the 12 o'clock position, which was the intended axis of placement of the T5 toric lens. The plan to implant a toric lens went sailing out of the window, and the decision to implant a hydrophobic single-piece acrylic lens was taken with its haptics positioned horizontally. The suspicious area of rhexis tear at 12 o'clock was coated with a bit of viscoat, and the lens was then injected with a B cartridge. However, between the time of lens injection into the bag and rotating it horizontally, it became evident that the tear in the rhexis had extended all the way posteriorly right down to the 6 o'clock position. Thankfully, due to the quick initial rotation, the haptics were already entrapped in the horizontal axis between the torn anterior and posterior capsular segments, while tapping down frequently on the lens with a Sinskey hook to make sure that there was no tilting and the lens was stable. There was a suggestion of a vitreous bulge at 12 o'clock, which was dealt with by injecting Pilocar to deepen the anterior chamber and bring the pupil down to add stability. This was live surgery, and the patient's son was a leading neurosurgeon who was also watching. This video shows the insecurities and perils of live surgery in a high-profile patient where an on-the-spot decision was taken to go ahead with lens implantation and lens stabilization in a capsular bag with extensive PC rent. A chance was taken with the post-op stability of this hydrophobic acrylic lens, which ultimately proved to be the right decision under the circumstances. The patient was seen on the 1st and 7th post-operative days and also 3 months post-op respectively. And to my amazement and delight, the lens was stable, as was evident in the anterior segment photo taken, and the patient's post-op vision was 6/9 with a refraction of -0.5 spherical with a residual -2.5 cylindrical error. The hydrophobic acrylic lens material benefited this patient with a shredded Coleslaw capsular bag with an unbelievable per-op and post-op stability, preventing the need to remove the lens per op and place a sulcus fixated lens or a scleral suture fixated lens. Like the racing car driver who had taken a rash and bold decision, I too, as an ophthalmic surgeon, had gone through a tense surgery and ultimately, with that bold decision, had come out scot-free.